Look, the real problem is healthcare prices. It's not patient failure to shop for care or how we pay for services.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management at the Naveen Jindal School of Management. Here at the University of Texas at Dallas, we bring together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare ecosystem. I'm Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any of the future episodes. You can also join us online at businessofhealthcarepodcast.com. Today's Business of Healthcare podcast is a special edition marking a milestone for our 100th episode. Being a special edition, we're fortunate to have a very special guest. Joining us today is Dr. John McCracken. John is a clinical professor of healthcare management at the Naveen Jindal School of Management, University of Texas, Dallas, and adjunct professor of family and community medicine at UT Southwestern Medical Center. He is the founding director of the Alliance for Physician Leadership, which offers a nationally recognized healthcare management executive MBA for physicians. Welcome to the Business of Healthcare podcast, John.
Thanks, Bob. I appreciate the invitation.
It's been a long time since you started the Alliance for Physician Leadership. Over the past 25 years, you've graduated over 500 physician leaders from around the country. What are some of the most significant changes you've seen in healthcare over that period of time?
Well, there are actually two very important trends come to mind, unfortunately, both adverse. The first is relentless healthcare inflation. Healthcare spending has grown faster than the national economy in, 16 of the past 20 years, and considerably faster in most years. By 2020, it was over $4.1 trillion, which is 20% of the entire economy. That averages about $12,000 per person, or about $32,000 per household. And that's a really heavy burden. It's been reported that over 60% of personal bankruptcies are caused by medical debts. The second trend that comes to mind is physician burnout. Burnout's been a major problem affecting healthcare providers for at least a decade. And the COVID epidemic has made it a lot worse. Over half of the physician workforce currently reports experiencing the major symptoms of burnout. There have been a lot of surveys that have shown high levels of emotional exhaustion, depersonalization, general feelings of low personal accomplishment. This has become a real major problem among physicians.
Wow, that is two very important trends. But, in the news today, we hear a lot about inflation everywhere, all the news feeds, everything. Specifically, let's talk a little bit about healthcare inflation. It's obviously a real problem. What do you think, what's causing this?
Well, that question has perplexed policymakers for over 4 decades. Today, there seems to be two opposing narratives that try to explain it. And each one has its own set of policy remedies. The first narrative holds that it's principally the result of patient behavior. I call this the patient as culprit. Now, the claim is because patients pay only a fraction of cost out of pocket, they got very little incentive to shop for cost-effective care. So the proposed solution is that patients need more skin in the game. They need to pay a higher percentage of cost. The other narrative is that rising costs are primarily the result of provider behavior. I call this the provider as culprit. The assumption is that fee-for-service payments incentivize doctors and hospitals to try to maximize their income by increasing the number of services. The proposed solution here is to try to change the way providers are paid, to reward value instead of volume. But you can see these two narratives propose entirely different policy solutions. And over the past 10 years or so, policymakers have tried to implement the recommendations of both camps, but so far nothing has worked very well.
So I like the word culprit. So we've got a patient as the culprit and we got the provider as the culprit. That's interesting terminology. So which of these two narratives, you mentioned both of them here, which one's more accurate?
Well, let's look at both of them. First, the what we call the patient is culprit. As I said, patients pay only a small fraction of total costs out of pocket. And also, they really don't have access to useful price data. And so as a result, they don't shop for care. The proposed solution is for patients to pay more of the cost themselves, as well as have better access to transparent price data. Now, the presumption here is that this would provide both the means and the incentives for patients to shop for more cost-effective treatments.
Well, we shop for everything nowadays. When you're buying a car or you're buying a house or you're even looking for someone to clean the house, you're always shopping around. You want to get the best deal. Do you really think this is true? Is that the case?
I've really got my doubts. Patient cost sharing has doubled over the past decade, but the evidence shows it hasn't really been very effective in encouraging price shopping. And in fact, particularly among low-income patients, it's tended to deter people from seeking treatment. High deductibles actually create very weak incentives for price shopping. It's because the cost of the more expensive treatments like hospitalizations, surgeries, exceed even the largest deductible. And the patients whose spending exceeds their deductible make up the majority of total spending. Another thing we find is that patients seem to be reluctant to disrupt existing physician relationships. Most patients really rely on their existing doctors to guide their medical decisions, and the advice they get is usually uninformed about relative prices.
Okay, I'm going to try to take sides here then. So I kind of get the vision of what you've talked about with the patient being the culprit. What about the other side of the coin here?
I call that the provider as culprit. Now, the belief here is the problem is the way that we've traditionally paid for care. A fee-for-service payment for doctors and per admission or per procedure payment for hospitals. Now, the assumption is that this payment for volume incentivizes providers to order more tests and do more procedures. And so the argument is if we change financial incentives to emphasize prevention and pay providers for value instead of volume, cost growth will be restrained.
Well, we hear a lot about value-based payments and things of that nature. So what do you think of this?
Again, I've also got my doubts about this too. Over the last decade, CMS, that's the Center for Medicare and Medicaid Services, has piloted more than 50 different alternative payment models that presumably reward for delivering value as opposed to volume. But so far, only 6 have generated any statistically significant savings, and those were only marginal. And when you subtract the performance bonuses from the gross savings, most programs either lost money or they saved no more than 1 or 2%. So far, at least, efforts to pay for value haven't really shown much impact.
I remember somebody saying once we needed a one-handed economist because on one hand, you've got this, and on the other hand, you've got that. And it kind of sounds like a similar situation here. So if healthcare inflation, if it's not the result of the patients, their failure to shop for care, and it's not the problem with physicians and how we pay them. So what do you think the root cause is?
Well, look, the real problem is healthcare prices. It's not patient failure to shop for care or how we pay for services. It's service prices. Over the past couple of decades, excessive drug and medical service prices unquestionably have been the main drivers of healthcare inflation. Now, between, say, 2015 and 2019, total per capita healthcare spending, at least among those with employer-sponsored insurance, grew 22%. Now, that was the result of an 18% increase in prices and only a 4% increase in utilization. So prices increased 4.5 times as fast as utilization. Clearly, if we're ever going to get healthcare inflation under control, we're going to have to find some way to restrain the outsized growth rate of drug and provider prices.
Well, John, you mentioned early on, there's a couple of these trends here. Inflation, I think we kind of covered the base on that a little bit, but physician burnout, I'm sure it's a serious problem. I don't doubt that at all. We hear about it, You've written about it before. But what do you think the cause is for that?
First, I think a better term than burnout is what we call moral injury. Now, that's the result of being forced to behave in ways that go against a person's deeply held values and beliefs. Now, doctors and nurses are deeply committed to putting the patient's interest first, provide care that's always in the patient's best interest. But today, doctors in particular are subject to an increasingly complex web of competing demands. They're subject to requirements from hospitals, from health systems, insurers, and regulatory agencies. In other words, they're being required to consider a multitude of interests other than those of just the patient. And I think they found that navigating an ethical path through all these competing demands has proved to be emotionally exhausting for most doctors. It's creating a loss of resilience and all the symptoms of burnout.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Well, when we talk about healthcare and we generalize it, we go, what a mess we're in here. It seems like there's a lot of things going on. I mean, you got high inflation, you got provider burnout. I asked the question, really, John, how in the world how can we screw something up this bad? I mean, how do we get to this point after all?
Well, I believe that the root cause is something that I call healthcare kludgeocracy.
What? Kludge what?
A kludge. A kludge is defined by the Oxford Dictionary as an ill-assorted collection of parts assembled to fill a particular purpose, a clumsy and temporary solution to a particular problem. Now, a kludgeocracy is a government built and run on quick fixes. It's one where the government tries to solve perceived problems in haphazard ways with patches and quick fixes. Now, the end result is a policy mechanism that's a lot more complicated than the problems you're trying to solve. I'll give you a good example is the Internal Revenue Code. It's now so complex that it's almost impossible to determine even how long it is.
Uh-oh, that sounds like a big multiple syllable word, John. Klugeocracy? It sounds like healthcare is a history of mistakes, or at least a history of policies that might have not fixed anything, but just kind of add to the burden. So in healthcare, how to become a klugeocracy? I can't even hardly say the word, it's such a kludge.
Well, I think there are actually a couple of reasons. An important one is our American political culture. On the one hand, Americans hold fast to the myth of small government and a preference for free market solutions. But on the other, they seem to believe that most important issues are proper subject for government action and oversight. Now, look, government can run a program like Social Security, or private markets can take over. But when something's privatized and yet at the same time government tries to exercise a high level of control, it becomes unwieldy. I'll give you an example. Take the Affordable Care Act. On the one hand, the ACA preserves some key features of a free market. It allows employers to continue providing health insurance. It also permits those without employer coverage to buy it in a marketplace. But at the same time, it's subject to over 11,000 pages of regulations. And these have created a mind-numbing level of complexity. This attempt to combine free market principles with strong government oversight has just resulted in a lot of administrative bloat. Also in a huge increase in physician time and resources required to deal with billing and reporting?
Well, there's got to be a number of factors there that maybe a root cause. I'm sure it's just not in one area. Tell us more about that, John, if you can.
There's another important factor here, and one is that healthcare is really a myriad of special interests. They're all fighting to preserve their economic advantage. During the past 2 decades, the healthcare industry has spent more than $10 billion on professional lobbying. That's more than 3 times any other American industry. It's more than the defense, education, automotive, and oil and gas industries combined. Last year, there were over 3,300 state and federal healthcare lobbyists, and half of them were former government employees. Now, one result of all that lobbying has been a huge accumulation of rules and subsidies and quick fixes. It's produced a complex set of healthcare policies and programs that have very little coherence or overall justification.
Makes me wonder why anybody would like to go into medical school or become a clinical provider if there's that much overhead involved. What kind of effect has this had, in your opinion, on the doctors and also the other clinical providers?
Well, as I said, it's been a major contributor to physician and nurse burnout, or what I call moral injury. It's also been a reason why, especially in recent years, physicians have increasingly given up independent practice and become employees. Today, almost 75% of all physicians are employed by a health system or insurer or some other corporate organization. And I'm not convinced that the corporatization of American medicine is really such a good idea. Time will tell, though.
That's a huge number. Almost 75% of the doctors, they work for someone. There's no longer the captain of the ship, I guess, right?
That's correct.
Wow.
Only 25% or so are in independent practice.
Well, John, these trends, both of them, healthcare inflation, provider burnout, I don't think they're getting any better. It sounds to me like it's progressively heading in the wrong direction. So is there anything at all that we can do to reverse that trend or slow it down or even stop them? Where do you think where does it end up here?
I think most people agree that these current trends are unsustainable. And I think to the memorable words of Herbert Stein, who's the former chairman of the Council of Economic Advisors under Nixon and Ford, he said, if something can't go on forever, it will stop. Now, I think that both the healthcare inflation and the kludgeocracy that we've discussed will eventually be brought under control. If something can't go on forever, it'll stop. But I also think it's not going to be the result of some creative new government program or enlightened reforms led by the nation's healthcare industry itself. In other words, I don't think it's going to be a soft landing. I think it's more likely there's eventually going to be a seismic shift in public attitudes and demands. And I think this will be the result of some powerful economic and financial forces of change that are going to originate outside of healthcare. But how that might evolve and possibly play out is going to have to be the subject of another day. I will say, though, Bob, that I'm an optimist. I do believe that sometime this decade, healthcare is going to experience the same strong economic and financial pressures for change that will impact the rest of the country. But I also believe that however healthcare is eventually transformed, it's ultimately going to prove to be for the better.
Well, I think that's a great way to kind of summarize things. I'd hate to hear you say that we're doomed. There's no hope. Pack your bags and go home. So I'm an optimist too. And I really believe that John, a lot of the things that we're doing here in terms of creating leaders in the healthcare space, when you look at the spectrum of physicians out there, what percent do you think are really leaders and what other roles do they have?
Well, from our experience, I'd say that probably about 5% of the physicians out there are really interested in role responsibility. That is a nominal leadership role as a chief medical officer, chief medical information officer, medical director. There's another 20% that I think, are what we call the physician influencers. Those are folks that don't necessarily want role responsibility, but these are the senior doctors that other people look to for guidance, support, counseling. And then maybe about 70% of doctors just simply want to practice good clinical medicine and be left alone, be left in an environment where they have the ability to do what they're trained to do. It's those 5% and perhaps the 20% that we call the influencers that are real key. I think that as healthcare is transformed, it's going to be transformed by doctors, not by government, not by hospital administrators, but by physicians. So as you know, Bob, that's the programs that we have here at the Jindal focus on healthcare providers, doctors and nurses, and equipping them with the knowledge and skills they need to really step up and into that leadership role.
Well, John, I want to thank you for your insights. I'm going to direct our audience to your blog as well. We'll put the link out there for your blog where you've written on these topics extensively and many other. There's a rich library of subject matter that you've covered. And I want to really say a bigger thanks for creating a learning environment for physicians that really gives them a chance to embrace this leadership role. And that's what's required. That's what's going to be needed here to really advance the true meaning of healthcare. So, John, thanks for your time today. We look forward to having you back on the Business of Healthcare podcast in the future.
Thanks, Bob. I very much enjoyed it.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu/healthcare.